This week, I'm joined by Lee Neely and hopefully April Wright to interview Brian Warren. He's the president and chief consultant at Warsec Security to talk about the challenges of healthcare security. In our second segment, we'll talk about the challenges of inheriting someone else's code. In the enterprise news, Docker Desktop for Windows 10 is going to switch for Windows Linux subsystem. Netscope introduces zero trust secure access to private enterprise applications. 10 notable security acquisitions of 2019. And so far, perhaps, can your patching strategy keep up with the demands of open source? All that and more on this episode of Enterprise Security Weekly.
This is Security Weekly, for security professionals, by security professionals. Broadcasting live from G-Unit Studios in Rhode Island, it's the show where we talk security vendors and aren't afraid to name names. It's Enterprise Security Weekly. The Viavi Solutions Observer Platform provides SecOps teams a powerful combination of comprehensive data for threat hunting and incident response that includes wire data analytics and enriched flow records. Using pure, unaltered packet and net flow, Observer presents views across the entire IT infrastructure with threat alert features including scope, impact, and advanced traffic profiling. Teams can use automated workflows to dive into high-fidelity network evidence and more quickly resolve issues, minimizing impact on customers, users, and business operations. Learn more about the Viavi network security solution and download free resources at securityweekly.com/Viavi. That's VIAVI. Is the fear of a cyber attack keeping you up at night? Are you worried that your business isn't properly protected? Keep your network up to date and secure from vulnerabilities with VSA by Kaseya. Kaseya's VSA patch management module installs, deploys, and updates all of your software from a single console. Kaseya's network antivirus provides real-time updates and ensures maximum security. Start sleeping peacefully all night long. To watch VSA in action, request a demo today by visiting securityweekly.com/Kaseya. That's KASEYA. The greatest threat to businesses today isn't the outsider trying to get in. It's the people you trust, the ones who already have the keys, your employees, contractors, and privileged users. 60% of online attacks are carried out by insiders. To stop these insider threats, you need to see what users are doing before an incident occurs. Observe It enables security teams to detect risky user activity, investigate incidents in minutes, and effectively respond. Get your free trial at observeit.com/securityweekly.
Welcome, everyone, to episode 142 of Enterprise Security Weekly for June 19th, 2019. I'm, of course, your host, Paul Asadorian, joined remotely right now by Mr. Lee Neely. Lee, welcome.
Good to be here. Well, greetings from Idaho, and looking forward to a great set of conversations today.
Absolutely. A couple of quick announcements. Make sure you register for our upcoming webcast with SaltStack, Logarithm, and ISC Squared and Viavi Solutions. Go to securityweekly.com/webcasts. If you missed any of the previous webcasts, you can check them out at securityweekly.com/on-demand. I'd like to now welcome Brian Warren. He's the president and chief consultant for Warsec Security, specializing in healthcare security and safety assessments and education. Welcome, Brian.
Hey, thanks, Paul. I appreciate you inviting me, and it's great to join you guys today.
Yes, nice to have you. And we're going to be talking about healthcare security, something we haven't talked about in a little while here on the show. And I know many folks listening to this show hold various positions in security in healthcare organizations, and it's a pretty challenging role to be in security for a healthcare organization. I'd put it right up there with universities, who may also have healthcare kind of facilities either on campus for the students or medical colleges in schools within them. So very challenging environment. What, in your mind, Brian, what are some of the top challenges that make it different from defending an enterprise that's not in healthcare?
Sure. So I think one of the things that when you're looking at healthcare security versus industry retail, and you're correct, probably the closest correlation would be that of higher education or of schools. It's because you're dealing with people that don't want to be there. Nobody goes to the hospital because
Yeah.
they want to. Think about that.
Mhm.
You're at the mall because you want to buy something. You're at the amusement park because you want to have a good time. You're at school because you want to learn something. But most people at a hospital are already having a pretty bad day. Unless you're having a baby, you're probably having a pretty stressful, unexpected day, and that's because you're injured, a friend, a family, something unexpected's happened that's going to
Mhm.
stretch your coping mechanisms to the max. So that in combination with, think about some of the unique aspects of particularly a hospital. They're open 24/7, 365. You can never just lock the door. You can't permanently ban anyone. So, if you
Mm.
act up at the mall, I can trespass you and ban you from the mall. I can say you can never come back to the Galleria, or you can't come back for a number of years. But federal law prohibits you from doing that because we still have to provide emergency care regardless of your behavior, regardless of your history. And then also think about the type of clients and patient populations that come to healthcare. You're looking at behavioral health patients. You're looking at people that have suffered criminal activity, gunshot wounds, stab wounds, overdoses. And that's in addition to all the day-to-day things. So it's a very challenging, as you had said, for a variety of reasons. But the biggest part is the people that you're there to serve don't want to be there in the first place most of the time.
Well, also, I don't think the hospital really wants, like, no one wants someone to be sick or hurt, right? And
Correct.
the hospital doesn't want more patients, right? Because that affects patient care. Also, they want to get patients in and out as quickly as possible, right? No one wants to be in the hospital for longer than they have to be. There's also the issue of hospital transmitted diseases, right? Which is oftentimes, I've noticed it in maternity wards, right? They're like, you want to go home? They're like, yeah, like you're out, you're healthy, everything's good, baby's good, you're going home, right? You're not hanging out in the hospital for a whole
Right.
host of reasons, right?
Exactly right. Yeah. Nosocomial illness or hospital acquired infections is certainly something you have to worry about. That's usually not something that you see a lot of unless you're on like a cruise ship or an enclosed environment like a
Sure.
norovirus. But yeah, that is certainly one reason that, as you said, you want to get in and get out as quickly as you can. And the other issue is, let's face it, it's reimbursement, and hospitals are a business, and
Yep.
let's face it, they need to have people coming and going. They don't have an infinite amount of beds to have people in for extended periods of stay.
Right. Yeah, and also if we focus a little on physical security, which is kind of roughly what we've been talking about so far, it's not just physical security, but when we talk about things like two-factor authentication specifically in a healthcare setting is very different, right? Because of the activities that are going on. You can't have a physical token that's transmitting germs or whatever, or people need to be using their hands, doing their jobs. They can't necessarily take a time out from, surgery or procedure to authenticate to a computer that requires usage of their hands, for example. Are there solutions that you have seen in healthcare that work really well in terms of authentication that are kind of a little more bleeding edge in terms of not requiring a physical second factor token, for example?
Sure. So if you go back a few years, to your point, especially in healthcare, proximity readers, that's one of the big reasons that they're so popular in healthcare. It's not just because of cost or setup, because it doesn't require that physical contact like a mag stripe used to. In fact, even some of what used to be higher tech biometric solutions like palm scanners, they're tending to get rid of those because you have to clean them constantly and look at things like iris scans or even maybe voice recognition. As far as bleeding edge, you're looking at facial recognition and some other things, infrared, as far as reading some heat, like from a first person's face. But you're not seeing a lot of hospitals adopt those. Now, in certain high security areas, for example, let's say you have a hospital that does a lot of oncology or cancer research, and this is true of universities as well. If you have a significant amount of radioactive source material there on site that you're using for legitimate purposes, you're probably going to want to have at least dual authentication, if not triple authentication, because there's bad guys that would love to get their hands on it. And unfortunately, radioactive material is one of those things that you can do a lot of bad stuff with very little. So you don't need a whole lot to cause a big panic. And that's where you're going to start seeing some of the investment in some of the more bleeding edge things,
Mhm.
but it's more because it's required. Let's face it, physical security still lags behind in many areas in healthcare simply because of the cost.
Right. Yeah, and radioactive material is more common in a hospital setting than most people might think, right?
It is.
My wife
That's
works in healthcare, and it's not just the X-ray machines, right, or whatever, or not X-ray, but in medical imaging, they use radioactive materials for diagnostic images.
That's right, and they also use it to irradiate blood samples. It's used for a variety of things. You've also got specialized cancer treatment areas, such as a gamma knife, that uses a very particular isotope that can be very bad if you get it out of its confines and use it in some illegitimate way. And again, you've got people that understand if you want to go take some radioactive material, you're not going to attempt to go to the nuclear plant. Let's face it, they've got barbed wire, they've
Right.
got weapons, they've got all these security, but a hospital has to remain open.
Mhm.
I always joke, you can't spell hospitality without hospital, right? You've got to look at it as more of a layered defense. So it may look open, but you really need to safeguard and harden that target when you get to the actual storage area. But again, it does draw attention. And to your point, a lot of people that want to get their hands on those radioactive materials understand that it's probably easier at a university or a hospital than other sources.
Yeah, and one of the kind of exposures, if you will, in hospital settings that's common is the older operating systems that are running on computers that are attached to any type of medical device or medical equipment, right? It could be as large as an MRI machine, or it could be, an embedded operating system in an IV pump or something. And what struck me recently, and I'm not sure why I never thought of this before, is, and I'm not sure who holds the responsibility, right? Is it the software company that makes the operating system? Is it the vendor that is developing the technology on an operating system? Or is it the client that has chosen that particular solution, which, I mean, let's face it, it runs Windows mostly, but yet they've chosen this operating system or designed this operating system, and it's being used in this environment that it has to be up all the time.
Mhm.
It has to be secure. And those are two things that are tough to get in Windows. You have to reboot it for patches, for example, right? And your software ends up tied to these patches, I think, more easily than other environments. Brian, why is it, do you think, that we've made this technology choice and it's pretty common in a healthcare setting? Why haven't we been shifting or moving, maybe we are, to different platforms and different types of software that are just more resilient, easier to patch, and more reliable?
I would say that a big reason for that, again, is because of cost. And let's face it, three big questions that most security people, and this is true in any industry, but particularly healthcare, are going to be faced with. And it doesn't matter what you're looking at: physical security, IT security, operational security. Your administration is going to ask, what's everyone else doing? Why are they doing it? And what happens if we don't do it? And if you look at the vast majority of
Brian,
places,
there's someone at your door, Brian. I recognize the ring. No worries. No worries.
Back to what I was saying, a lot of places, when they start looking at investing in some type of infrastructure or some kind of specialized security, particularly on the IT side, one of the questions that is going to be brought up is, well, what's everyone else doing? And to your point, it's almost that catch-22. Well, if everyone else is using this type of software, that means that it's easily available, that it's probably less expensive. It's not a one-off that we have to have specialized knowledge or talent. Again, it all boils down to, let's try to make it as homogeneous as possible. And unfortunately, that's the case not just in IT, but in physical security as well. You see a lot of what people consider security solutions for no other reason than they were either the lowest bidder or, well, that's what everyone else is doing, and we don't want to be the first to try something out. Right. Now, you have a few healthcare organizations that are proactive. They want to get out there. They really want to be innovative and try things, but you don't see a lot of trailblazing when it comes to security because, again, it's a very costly endeavor, and we just don't have the same political clout as some others in healthcare, for example. When you're looking at nursing shortages, when you're looking at specialized equipment, particularly diagnostic equipment
Yeah.
that is going to, produce revenue for the organization, and you have a finite bucket of finance, security is usually at the bottom of that list unless something has happened. Then they're going to reconsider, and you can probably get some funding.
Well, yeah, and Brian, it's a great point. When I think we choose any technology, we typically, in almost any scenario, right, we typically don't go with the technology that has the least adoption for a lot of reasons, right? Like, it hasn't been fully tested. If they've got 75% less of a user base than other software that's more popular, that software has largely not been tested in the real world as much. There's not as much support in other people that you can call on. There's not as many consultants, for example, that you can bring in to work on that software. And I think those are some really good reasons why we end up with commodity Windows operating system with more commodity Windows software, because it's well documented. A lot of people are developing on that platform. That's probably why the vendor chose it, right? And that just trickles down to the consumers of that technology.
Well, you also have to look at interoperability because of the HITECH Act and some other things that were signed into law a few years ago about electronic medical records, how they should be used, how they have to be used, things of that nature. You don't want to get something that is going to cause you problems, and you have to constantly create new ways so it will talk to your neighbor. If I'm a patient at hospital A, and I choose for whatever reason to go to hospital B, my electronic medical information has to be able to seamlessly move from A to B. And if hospital B is using some unique system, then that could cause problems. Again, that's going to be an increased cost. And there's also the opportunity there that not all the information gets through. Something may get corrupted. So again, unfortunately, it's fallen down to let's go to the lowest common denominator. And you see that in a lot of different systems.
I had a question.
Go ahead, Lee. Sorry.
Last week there was a story about a medical gateway. I'm forgetting the particulars, but I still got enough. That was essentially running Windows CE that had an RDP vulnerability in it. And my question isn't why are we using that. My question was a lot of the recommendation from security practitioners was not only patch but segment the network to better protect these things. And I'm wondering, how does that look from the other side when you say to the hospital, we need to segment or update these devices that really need to be clicking along 24/7? What's the pushback from the other side, or is that okay and accepted?
Lee, you're getting into an area that's a little beyond me. I don't do a lot of cyber and IT security, and that's probably best to somebody that does that. I'm much more of an operation and physical security person. I would like to answer that, but unfortunately, I am not educated enough in my wheelhouse to really speak to why someone would do that.
No, I was more, and I may be off your wheelhouse. I was thinking of what's the impact when an outsider comes in with a let's fix your cyber or physical, without consideration of what the hospital would be thinking about for how they architected their network. So maybe in a different vein, one thing that I've been worried about, we've been talking about the hospital level and what you've got going on there. What happens when you move out of the hospital out to the clinics or the medical offices? What does the bar go down, up, left, right? How does that translate to the individual doctors trying to get their job done? Or is there really no mapping?
No, you actually see a dramatic drop. In fact, it can go from there's a pretty wide spectrum there. So look at your hospital. We'll talk about an acute care hospital. And by that, I mean it's a bedded facility. People are going to be there overnight. Typically, you have an emergency department. You may or may not have labor and delivery, behavioral health, all the specialty units. So your typical full hospital, full services. Now, let's go down a notch, so to speak, and you're going to move out to maybe an urgent care or an ambulatory care center in the community. You may have some similarities when it comes to security. They'll certainly probably run the same type of IT and cybersecurity as the parent organization or the parent, hospital. And you may have some physical security, limited CCTV or surveillance, limited physical access controls, but you're probably not going to have a physical security presence. In other words, any type of guard force there. You're probably going to have little to no training of the people at those isolated areas. And again, that's where it really comes into, they're going to rely on local law enforcement or police more than internal. And then you can go a step further. Think about home health care workers. And that's something that a lot of people don't think about in healthcare. These are people that are practicing healthcare in another person's home. So you can imagine that the only thing they've got with them is their device, their phone, their tablet, and then the knowledge that they have from proper education. They literally have none of the protections offered by the home organization when they're at a person's residence. And you can imagine some of the things that they see on a day-to-day basis. So it's a pretty broad spectrum of security, not just based on the organization or the type of organization, but where you are in that organization.
Brian, I wanted to ask about physical security. As my wife works in a healthcare environment, and she very vividly describes, what it's like to work in healthcare, and it's a very busy place. Like a lot of us have probably been to the hospital at some point, right? I mean, there's people running around all over the place. They're not necessarily paying attention to any kind of physical security. That's really hard because their jobs are consuming them, yet it has to be an open environment. What is your kind of like top advice for, those listening that are responsible for protecting a hospital, for example, in terms of physical security, to improve their physical security?
Sure. I think step one, and again, you can look at low cost, high cost, low cost, no cost, right? Step one is a proper orientation for staff and make sure that they understand why security has to be everyone's responsibility. Mm-hmm. And let me elaborate. I don't think that nurses and other, physicians and other direct care providers need to be chasing people down the hall, tackling them if they do something wrong.
Agreed.
But they do need to know what the organization or the hospital considers as suspicious or unusual behavior. They need to know where their panic buttons are if they have them. They need to know the phone number to call to reach security if they need them. These are really basic things that people take for granted. But believe it or not, when you're looking at orientation for new people coming into healthcare, they're constantly looking for ways to make it more efficient. And, we need to carve a few minutes out here and a few minutes there because we want to get these people through as fast as we can. So we're not going to talk about security. They'll learn that on the job. Well, then people get on the job, and as you said, who's got time to learn anything because you're hitting the ground running? So somebody may have told you, here's the code to the break room, and here's the way the ID badge works, and there's a panic button under the desk if you need it. But that's really not good enough. So I would say on the low end, education orientation is one of the biggest things. We also need to look at some, and I hate to use the word standards because that's a really tough word, but we really need to look at, regulation is not very prescriptive. In other words, they're not going to tell you in a OSHA or any of the big accreditation agencies are not going to spell out, you have to have this type of lock set on this type of door in this type of unit. They're going to use words like reasonable precautions, and security sensitive areas should have a heightened, security, physical environment, things of that nature. That's why it's important to get someone that knows what they're doing to get an assessment and to take a look at that physical environment. Don't leave that up to the caregivers because it is a specialized field. You really need to get somebody in, and let's face it, nobody likes security for one reason, it's not convenient. I don't want to have to badge in a door every time. But again, things change when a bad event occurs. So we really need to work together, get a lot of different groups together, especially your clinical folks, and explain to them why things like tailgating a door is important. And that may seem small, but that's actually huge. If you let someone in behind you, you badged in, and then you let the person in behind you. If I don't have a camera, then I'm going to assume that you allowed them in purposefully. You see what I mean? It's very difficult to prove what happened, and that seems basic, but it's surprising how many places have eliminated that from the orientation of their clinical staff.
Well, and it's surprising to me because I find hospitals are very good at implementing policies and procedures, right? And I've watched the progression over the past 10 years, and because of wrong side surgeries, because of mistaken identities, the procedures that are in place today are very stringent, and it took time, I think, for people to implement them correctly. But for example, where my wife works, she told me all about how they validate the patients, right? They ask for your name, and you've probably been to a hospital, right? How many times they ask for your name and validate your date of birth? They're making sure you are who you say you are before you have any kind of test or anything, right? Give you Tylenol, doesn't matter. They're validating who you are. When they do a procedure, there's multiple points now where they've built into their procedures. They have to check with the patient to make sure, is it your right upper quadrant? Is it your left leg? Is it and then they'll take timeouts, and this is all built in their procedures. And in speaking with Ira Winkler a couple of weeks ago at Layer 8, it was his strategy for to prevent against social engineering attacks and physical security attacks, to make this what I think is a similar type of procedure. Make it very easy, make it clear cut. Tailgating is a great example, Brian, right? Tell them, you don't even have to tell them about tailgating, right? One person through the door who is authorized at a time. That's the rule. That's it. Just like in a procedure, at least 3 times you will verify with the patient that they're having a procedure on the right leg, if that's the leg they're having surgery on, right? So I think it's totally possible. I think it's just some education that has to be done.
I would agree. And I think part of it too, Paul, that you're looking at is when you're talking about all of the safety, especially when it comes, identify the patient properly, a lot of that grew organically out of the need because of malpractice and litigation. And unfortunately, I hate to put it this way, but a lot of security issues, hospitals are willing to roll the dice until something bad happens.
So true.
And that is changing now, especially with some of the new legislation that's being thought about as far as OSHA. One thing that a lot of people don't realize is OSHA, regardless of industry, and we're not just talking about healthcare, we're just talking about in general, OSHA does not have a specific regulation regarding workplace violence. They never have. And in healthcare, that is particularly troublesome because healthcare has the highest workplace violence rates of any industry in the United States. Nobody's even a close second.
And is that because of due to patients? I mean, because my wife has stories about patients that just go nuts and start attacking the healthcare professionals, right? It's very, very scary. I'm concerned for my wife's safety. Oftentimes.
Absolutely. You've got behavioral health patients that are simply wanting to get away. You've got victims of violent crime, but you've got average everyday people that are placed in extraordinary circumstances, and their coping mechanism just can't quite deal with what's going on. And so, all these things combined in one place, it's the perfect storm for workplace violence if you think about it. So healthcare, I would say, because of some of this, OSHA is now seriously looking. I know that a bill was submitted in November of last year to actually create some workplace violence legislation so that there's a requirement, because as it is now, there's just a patchwork of some different regulatory language that hospitals have to comply with, but none of it really speaks to what has to be done when you're talking about security training for your staff.
Maybe the education needs to be to the board of the hospital, or somebody higher. Maybe the doctors don't necessarily need to understand the law, but the people that are making.
Oh, hey, April. Thanks for joining us. It seems your audio is breaking up a little bit. Yeah, it's kind of choppy.
Yeah, I'm sorry, I couldn't understand your question. I apologize.
Technical difficulty. I don't know what to say.
Maybe move your laptop a little closer. It sounds like it's getting cut off a little bit.
Yeah, I think the connection.
Gotcha.
So I was saying that maybe the education needs to be done to the board versus the doctors themselves.
Say that again, April. Sorry.
I think April's asking if if education is needed at the board level rather than at the doctor-physician level.
Oh, absolutely. Again, I think that it's important that everyone, and some states have already, taken this into effect. California, for example, Massachusetts, are now requiring that anyone that works in the healthcare environment, regardless of your role, has to have at least some type of minimal training on security, on safety, things like workplace violence. administrators, until it's important to boards, to the real decision makers. That's really the biggest challenge. I've said for years.
April's trying to call in on Skype.
Security and safety really need to do what risk management did. 25 years ago, the practice of risk management in healthcare was just another hat that someone wore in workman's comp or insurance or human resources. And now it is one of your most powerful departments and divisions in healthcare, because it can show an ROI for the preventative measures that it undertakes. And I think security needs to be viewed the same way.
Absolutely.
So you're saying that there's
ahead.
I would say, so it sounds like the after risk management, the next big opportunity that needs to become no longer an and also is security.
I think so. A lot of it's going to be not just because of legislation or regulatory and accreditation. It's going to be a must-have, but it's going to be where you're going to have a workforce, and we've already seen that. You've got a generation of people that are coming out of school now that don't accept workplace violence and security risk in healthcare as part of the job. 25 years ago, nurses that worked in the ED, and I'm not saying this was right, but they understood that, I'm going to get bit. I'm going to get punched. I'm going to get sweared at, spit upon. That's part of the job working in the ED. But it never should have been that way. And you've got a generation of people now that are saying, no, that's not what I signed up for. And if they don't feel safe working somewhere, they're going to leave. And that is a huge cost to replace, especially some of these experienced specialty clinical folks. I think that's going to be a big driver for administrators.
Agreed. So, Brian, tell us a little bit about your company. Is it are you like an independent consultant, or have a team of people, or?
Yeah, we do security, physical and operational security assessments, mostly in the healthcare environment. Have done some other industries, but I've got 30 plus years in nothing but healthcare. So I do everything from looking at your policies and procedures, your educational methods, your training programs. I then compare that to your local, state, and federal regulations and accreditation. And I really try to help people understand, what's the best way to do something without spending a lot of money. I understand that you don't have millions of dollars to throw at a security solution, but there are some best practices out there that can really be adopted. And that's really what we specialize in, trying to make as safe an environment as we can for patients, but also for the staff that are providing that healthcare.
Fantastic. Well, Brian, thank you very much for appearing on Enterprise Security Weekly. And with that, we'll take a short break, come back with the enterprise security news or a topic, whichever one's next. It's going to be good, though, so stay tuned.